to present our speaker today, Dr. Vidya Sundareshan. She's a professor and chief of infectious diseases at Southern Illinois University in Springfield, Illinois. She's the program director of the Adult Infectious Diseases Program, medical advisor for the Sangamon County Department of Public Health, and American College of Physicians governor for Illinois South Chapter. So please help me welcoming Dr. Vidya Sundareshan. Thank you so much for being here.
Thank you so much. And it's very special for me to be introduced by my a good friend and colleague, Dr. Marcela Rodriguez, who's also in infectious diseases at a pediatric department at SIU School of Medicine. So thank you, Dr. Rodriguez. Today's topic is going to be a stepwise wound care. Without further ado, I'm going to jump right into this because there are quite a few slides I want to go through. So what I'm going to be kind of talking about is review of the pathology of wounds, management of chronic wounds in a stepwise comprehensive approach, and then also using diabetic foot infections. Infectious Diseases Society of America has some updated guidelines that, and then venous ulcers as a paradigm to give you an overview of how we manage wounds. So, as you know, wound is a disruption of the normal structure and function of the skin and skin architecture. You can have acute wounds or chronic wounds. Most times, what we see in the adult world is really chronic wounds. And here, the wounds have been present for over 2 to 4 weeks. The normal healing process is complete by 4 weeks, but this has not occurred in chronic wounds due to some physiological impairment from chronic comorbidities people may have. Epidemiology wise, more than 6 million Americans suffer from chronic wounds. There's over 1 million new wounds each year. And then a majority of those are in the elderly, but you do see those in younger patients as well. 3.5% of Americans over the age of 65 years have venous ulcers, and over 1 million Americans suffer from pressure ulcers, and then 25% lifetime risk of development of any kind of ulcers in 18 million Americans with diabetes. And then the cost is over 50 billion in terms of management of wounds. So this does lead to a lot of morbidity and mortality. And another way of looking at this, if you look to see in comparison with colon cancer, prostate cancer, it's there. It's not quite up there, but it's still comparable. So you do see that neuropathic ulcers, amputations. It's a big problem in comparison with lung cancer or some of the others. And you'll see that a peripheral artery disease is arterial disease, diabetic foot ulcers. They're all contributing quite a lot in terms of the 5-year mortality rates as well. And then in terms of ulcers, diabetic ulcers leads the pack there, and then arterial venous ulcers are next, pressure ulcers, sacral decubitus ulcers, or any of the other pressure ulcers, surgical wounds, burn, trauma. All that is a significant part of this paradigm of wounds that we see. So for wound healing, hemostasis is the first phase. Then you've got the inflammatory phase, proliferative phase, and remodeling that usually occurs. But when there is hypoxia, which is the biggest offender there, there is no angiogenesis. There is no reactive oxygen species, which boosts the healing phase. And then remodeling can also be affected when there is some kind of an impairment in the collagen pathology there. So, for chronic wounds, they could heal by first intention, second intention, or third intention. And then again, in all of these, the phases that we were talking about in terms of hemostasis, platelet aggregation, neutrophil migration, monocytic migration, granulation, all these can be impaired to cause scar formation and then impaired healing. From an infectious diseases standpoint, this is something that we typically look at. wounds can be contaminated. So if you look at it, it is a spectrum. Wounds can be contaminated. You don't want to be treating contaminated wounds with antibiotics. So this is something to always keep in mind. There's always, when you have a break in the skin flora, there's going to be bacteria, environmental bacteria, the things that settle down in the wounds. So wound contamination. And if you have the proliferation of bacteria there can lead to colonization, can lead to critical colonization, which eventually leads to wound infection, where you start seeing more localized or even systemic manifestations of those. You can have erythema, you can have purulence, you can have pain. Remember, with rubor, dolor, color, pain is also a very, very important manifestation of wound infection. And then you can have this advanced wound infection, again, with systemic manifestations as well. Sepsis can occur from this as well. And then the organisms that you usually see in wound contaminations would be your skin flora, regional flora, coagulase negative staph, diphtheroids, some anaerobes. And then, as the progression occurs, you will see that, you can see gram-positive bacteria. And I'll talk a little bit more about this in terms of what kind of bacteria regionally too. There's data that regionally too, there is some variation in terms of what kind of bacteria that you can expect. And then, of course, multi-drug resistance plays a big role in this. All right. It is important really to know the patient beneath the wound. So there are stepwise approaches. First, it's and foremost, obtain a complete history of the patient, and then the origin of the wound and what has the patient done so far for the wound. It's very, very important to get that history. Then, with the review of systems, you want to get the comorbidities to understand what could be the underlying reason why the patient develops this wound. Determine the location. Location is very, very, very important. It's key to understand what the pathology is. And then, other things that you can do for the wound in terms of measure, a complete vascular assessment, common pathways that you can assess for to see where the wound healing has been impaired. All right, this might be a good mnemonic to keep in mind. Timed, see what tests have been previously done. What are some of the influencing factors? Is the wound actually better? Is it worse? Also, look at what prior treatment methodologies have been used. And then that would give you an idea for the etiology. How long has the wound been present? So for the history, this might be something that you can keep in mind, timed a mnemonic that you can use when you're getting a wound history from patients. Location again is very, very, very important. If the lower extremity wound is been below the inguinal ligament, then you want to definitely look for vascular reasons. So I'll come to this a little bit more later. So location again is key. Where do you find venous ulcers? I'm sorry, this I would have loved to have this session be more interactive, but it's not quite possible in a webinar format. But think about it. Where do you find venous ulcers? So medial side of the ankle, lateral side of the ankle, so around the ankle area. If there's a wound present, that's most likely a vascular ulcer. 70 to 80% of the vascular ulcers are venous. You also have arterial ulcers, which could be from emboli, vasculitis, small vessel disease, atherosclerosis, and then don't forget lymphatic system. So lymphedema can also cause a lot of these ulcerations in similar areas in the lower extremities. Tip of the fingers. This kind of tells you that there is, or tip of the toes. This tells you that there's an arterial component for the wound, a gangrenous wound, necrotic wound at the tip of the fingers will, or tip of the toes will kind of give you an idea of the pathology there. Neuropathic ulcers with diabetes, a spinal cord injury, take scabies dorsalis, any condition where your sensory impairment occurs, neuropathic ulcers, non-vascular pressure ulcers, burns, frostbites, spider bites, etc., can also cause those non-pressure ulcers. If you have a ulcer or a wound appearing in these pressure areas, over bony prominences, the medial, lateral, metatarsal heads, calcaneum. All these areas kind of tell you more that this is perhaps a diabetic infection, or where there are pressure areas, sensory impairment. So that gives you an idea of what the pathology could be. So again, location is key. Remember that. All right. So for physical examination, it's also important, apart from just looking at the wound, look at the skin, hair, nails, look for necrobiosis, lipodermatosclerosis. You'll see that with the diabetic wounds as well. Skin is extremely thickened. Calf circumference can give you an idea of vascular ulcers. Pain, definitely assess for pain. We talked about this earlier. And then necrosis, pulse examination, oxygen perfusion testing, very, very important. So these are some of the ways that you definitely look for vascular ulcers, and I'll talk again a little bit more in detail in terms of vascular assessments. All right. Measuring the wound, very, very important. The size of the wound, look to see how much is covered with exudate or how much of slough you have. That's a very nice way of, prognosticating as well. Today, the wound is 80% covered with slough. So, or 60% granulated, 80% granulated. So that kind of gives you an idea as to how much progress the wound is making. You want good granulation tissue, so 80% granulation is much better than 60% granulation. How much is covered with slough? So all that is a good way of assessing the wound, even for prognostication. And appearance of the surrounding skin. Remember always also to look at the surrounding skin. Is there erythema? Is there cellulitis, peri-wound cellulitis? Is there undermining of the wound? Is the skin overhanging? Is it kind of healing properly? Are there any kind of fistulas present? So those kind of things you can assess, and also help for prognostication. So every time we see patients in wound clinics on a weekly basis, and the assessments are always done with these templates that we have. What is the measurement of the wound looking like? How much is it covered in slough? How much granulation? What does the peri-wound area look like? What is the pain rating that the patient will give you? And if you do this on a weekly basis, you will see, you can definitely make an assessment of how the wound is improving or getting worse. If you're not doing the right things, it will give you an idea of what you can do differently. So this is a very, very nice way of assessing the patient frequently. Even the patient is in the hospital. Daily assessments sometimes may not be very useful because the wound doesn't change so fast. But then, in an acutely ill patient coming in for, let's say, a diabetic foot infection, has had surgery, you're assessing, you can still use this paradigm to see if something has acutely changed as well. But this is more useful for a weekly assessment of chronic wounds. All right, some ancillary testing, cultures, blood work, etc. Again, we'll talk a little bit more about this in detail, but keep that in mind when you're working patients up as part of the measure the wound and the wound patient. Okay, and then identifying a common pathway to wound healing here. Infection, malperfusion, hypoxia, cellular failure, unrelieved pressure, trauma. So look at the patient as a whole to understand what is causing this chronic inflammation. In that case, defining comorbidities is also very, very useful. diabetes, renal dysfunction, with or without dialysis, ischemic heart disease, cardiomyopathy, congestive heart failure, smoking, seizure disorder, malnutrition. We often forget that malnutrition. And then also visual impairment, auditory impairment, all these we don't really think about, but they are also very, very important to look at the patient as a whole to see exactly what we can do better to make the patient's wound heal better. All right. Talking about measuring the wound and the wound patient, culture, histopathology with a biopsy, blood work, diagnostic radiology in case there's any concern for osteomyelitis, EKG, chest X-ray, especially if somebody is going in for, let's say, hyperbaric oxygen, you want to even get an echocardiogram, EKG, all those ancillary tests, getting upfront would be very, very useful. And then any consultation for comorbidities that you can seek. All right. So, in summary, for the wound basic assessment for patients, getting complete history of the origin of the wounds, care of the wounds so far, method of prior treatments, obtaining a review of systems, comorbidities, location of the wound, vascular assessment, measure, which is the mnemonic for measure, exudate, appearance, suffering, which is pain, undermining, reevaluation on a weekly basis, and then looking at the peri-wound area or edges. Keep that in mind for wound assessment. And then identifying the reasons for wound healing failure. So define whatever applicable comorbidities, the big list that we went through, key therapeutic care recommendations that will apply based on the comorbidities, and in selection of appropriate clinical practice guidelines if it's a vascular ulcer or diabetic ulcer, and in monitoring response to therapy. Okay, so that would be for knowing the patient under the wound. Remember, wound care is actually a team sport. What do I mean about this? So, essential principles for wound care. It's really nice to follow this in a systematic manner, and that way you'll not miss anything. And many a times, even in infectious diseases clinic, we see only part of the wounds are infected. Not everything is infected. I'm an infectious diseases doctor, but I also do wound care. So in my clinic earlier, before I was trained in wound care, I was first an infectious diseases fellow and an early career physician in infectious diseases. See a lot of patients that were referred to my clinic for wounds, and I would keep giving them antibiotics. I almost always felt that the antibiotics are the solution. No, antibiotics are a solution for a very, very small part of these chronic wounds. So following the stepwise approach, many times I realized when I started doing wound care, the patients that would come with significant edema in the legs, and then I'm still giving antibiotics and I'm doing other things which are not helping the wound at all. You control the edema, the wound is starting to heal already. So the stepwise, very logical way that you assess wounds and you follow this in a stepwise manner, then you're likely not to miss what the cause of that wound is. So we'll go over that now. So really, the first step is here to try to assess if the wound has adequate perfusion, adequate oxygenation. You want to make sure that that is first taken care of. If there is no perfusion, if there's not enough oxygen getting to the wound, no matter what you do, it's not going to heal. Okay, so that's the first step. Next, if there's any non-viable tissue, okay, so if there's a slough, there's dead tissue there, it's not going to heal. That has to be surgically removed or has to be debrided mechanically, some way or the other, remove that non viable tissue that's present. That's step number two. Step number three would be infection. So, if there are any signs or symptoms of infection or inflammation, address it. You've got to treat that with antibiotics when applicable. If there's surgical resection needed at this point because the antibiotics are not good enough, that point, infection needs to be treated. So that's number three. Number four, if there's any edema, if there's lymphedema, if there's edema because of a chronic venous disease, all this needs to be addressed. That's number four. Number five, microenvironment. You have to make it conducive to healing. This is a very simple principle. If the wound is dry, give dressings which add moisture. If the wound is wet, then add dressings which absorb the moisture. So, very, very simple principle there of giving a good microenvironment that's conducive to healing. Next, is the tissue growth optimized? If you have a big open wound, what are you going to do to try to close that gap? We talked about primary intention, secondary intention, and then a third intention where healing with scarring. What can you do? There are so many new things now in terms of even nanotechnology, stem cells, so many things that you can do to optimize tissue growth. Negative pressure wound therapy started by a nurse, brilliant. It's just application of negative pressure, so the tissue is just pulled together and sucked together to close. So is tissue growth optimized? What can you do? So that would be the sixth. Next is offloading, particularly important for pressure ulcers, diabetic foot ulcers. If they are constantly walking on an ulcer that you're doing all this for, you're making sure perfusion is good, you're treating them with antibiotics, you're making sure you're giving good dressings. But if the person is just constantly walking on that ulcer and adding insult to injury, it's not going to heal. So offloading, have you given a total contact cast or have you given proper shoes? Offloading that ulcers, very, very, very important. Then is the pain controlled? Many times we forget this. Pain control is important. Then neuropathic ulcers, some of these, they don't feel the pain as much, but then vascular ulcers can be extremely painful. So is the pain well controlled? And that also adds to the overall morale for the patient to be motivated to get the wound healed. And then host factors optimization. If it's a diabetic, make sure the sugars are well controlled. If it's a vascular patient, making sure that they're getting their compressions, they're on medications that control venous hypertension. Is their hypertension well controlled? So all those are also, host factor optimization for wound healing. So these are the stepwise wound care essential therapeutic principles to keep in mind and not to miss anything. And it's better to kind of go in the same order. You want to first make sure perfusion, oxygenation is taken care of before you apply a contact cast or before you apply compression. So if somebody's not got good perfusion and you're already applying compression for edema, that may not always be the best thing. If the arterial system is impaired and you're applying compression, that may not always be the best thing. So, stepwise following this would be very, very useful. And I also want to point out one other thing in this slide that look at how many different specialties or other, specialty uh, people that you can get help from in order to get your wounds to heal. So, wound care is definitely a team sport. So, you will probably need a vascular surgery colleague to help you out. You're going to need an infectious diseases doctor. With microenvironment conducive to healing, our nurses are the best. They know exactly what dressing to use, which will work for the patient. Is there edema? If there's lymphedema specialist, we use an occupational therapist there for control, helping with lymphedema. Is tissue growth optimized? Plastic surgery helps with that. Even for that non-viable tissue present, plastic surgery helps with that. So, and then again, endocrinology. I use a lot of pain medicine specialists as well for optimal pain control. So this is definitely a team sport, and you need multiple people to help you out in terms of taking care of the patient adequately. All right. So now I'm the next few slides, I'm going to kind of go over the details of what we spoke. And I'm not going to spend too much time because I spent a lot of time in that the first slide there that kind of introduces the topic, but I just want you to see there'll be some pictures which will help you understand as well. So for vascular testing, macrocirculation, microcirculation, ABI is the most important. If you don't remember anything else, just remember ABIs. You want to make sure that there is adequate circulation. You can also get a toe brachial index (TBI), which is a little bit more sensitive. If there's a lot of calcification in the vessels, ABI may spuriously look like it's very high. But take that in the context of the patient. TBI, also get a toe brachial index. That will definitely help you get the correct values for that. This transcutaneous oxygen monitoring, not that useful, skin perfusion pressure, etc. So there are also other modalities for microcirculations. I don't use this in a wound clinic. I don't know how to interpret a lot of these things. So I just, if there is any concern, I send patients to a vascular specialist who can give, specific interpretations of their tests. But ABI is something that I can order upfront. In clinic, how can you assess if there's a problem? First, never forget that pulse. Looking at the pulse is so important. So in clinic, always look at the pulse to see if there's any problems that you can identify clinically, and an ABI would be the test. So these are some of the non-invasive vascular lab tests which could be ordered, which are ordered for wound patients, but in a wound clinic setting, and as an infectious diseases physician that's in wound care, I check ABIs and TBIs, and then I send the patients over to vascular if there's any problem there. So again, how do you interpret this ankle pressure and then brachial pressure? So if there's a difference, you typically want this to be one. If it is less, then there is either mild to moderate disease if it's in the range of 0.41 to zero point 0.9, and if it's less than that, that's 0 to zero point 0.4, the severe peripheral artery disease. Um, all right. So this is something that you can use in clinic. Dopplers, if you don't have this in clinic, you may want to get this. Always, I don't always find the pulse, but then with a Doppler, it's easier. So definitely try to get that in clinic if you don't have that. So this is something that you can easily do bedside on physical examination. So ABI as a screening tool, it is pretty sensitive and specific. Sensitivity is 95%, specificity 100%. But do keep in mind that when there's that non-compressible range greater than 1.3, if there is calcification in the vessels, you can spuriously get this higher ABI with diabetes, renal failure in elderly patients. So something to keep in mind. And again, TBI combined with the toe pressures, it becomes a very useful tool. There's a problem there. You can reach out to your vascular colleagues. Revascularization of critical limb ischemia, not only critical limb ischemia, but then ischemia that's present. You identify this. Revascularization is the first thing that you really want to do. Stents are an easy way to do that. Vascular literature is evolving. We used to use a lot of invasive surgeries and, bypass surgeries, etc. But then came these stents, and stents became a really easy way. It's an outpatient surgery. Patients had stents. The problem is that it comes back. So, they're not permanent. They're not permanent solutions. So a lot of the patients need stenting again. So that is one issue that is being recognized, and sometimes putting stents again and again can also cause a lot of scarring in the vessels. So vascular surgeons and their guidelines now are kind of evolving there as well. Right procedure for the right patient. It's their expertise, and many a times I just send patients out for referrals when I do find a problem. So that's something that you want to definitely make friends with vascular surgeons and keep them on your team for wound care. All right. So venous ulcers, you've seen a lot of these, but again, just to show you what the pictures may kind of look like. Here, compression with two-layer wrap, four-layer wraps can be very, very useful. And again, sometimes when those ulcers are there, you can also use a Una boot with some zinc coating on top of that ulcer that helps healing as well. And then, utilizing these, changing this once a week, etc., can be done in clinic as well. With venous hypertension, this is just a picture to show you there's such intense disarray of the blood flow causing edema as compared to the normal flows with valves that are highly functional. Here, the valves are also not functional, plus the blood flow is just so disarrayed there, causing a lower extremity edema. There's also other ways of clinical description here, C0 to C6 phases, based on what the legs may look like. The first stage is really heaviness in the legs with pain, then telangiectasias, then visible palpable varicose veins, then venous edema. Then you start seeing these atrophic changes with this whitish lesions there called atrophy blanche as well, on where you can see that in C4. And then ulcers with trophic changes, and then presence of active venous ulcers is the last stage there. So telangiectasias here, again, um, earlier signs, then you see the varicose veins, you see that stasis, dermatitis in this picture, and then the ulcer with, eschar formation there. And then one more thing to keep in mind, you see these heaped up appearance on the edges. You want to make sure it's not having any malignant transformation there, marginal ulcers. So you see ulcers like this, biopsy is warranted there as well. Okay. Next is debridement. For debridement, a sharp versus non-selective debridement can be done. You really want to decrease the bacterial load and biofilm. Many times when we see patients in clinic on a weekly basis, when we debride, it really makes a big difference because you're mechanically removing a lot of that biofilm as well. So there's endogenous growth factors which also get stimulated, and then you're controlling the pathology there. So debridement is very, very important. Next, for infection, local signs are very, very useful in identifying this. So cellulitis, there's a lymphangitic streaking, purulence, malodor, wet gangrene. All these can be, signs of infection. So keep in mind, and systemic signs, fevers, chills, hypotension, hyperglycemia, leukocytosis, confusion. So all those could be physical signs there. For edema, the calf muscle pump is failing here. So deep veins, superficial veins, venous valves, and muscles in the inelastic fascia are all not working there. So the work has to be done against gravity here. So a fluid starts to accumulate in the lower extremities. So, always make sure there's arterial perfusion, good perfusion before applying compression. Remember, we were talking about this earlier. So if you start applying compression and arterial perfusion is not good, you can just cut off circulation completely to that leg and making it worse. So remember to keep that stepwise management in mind. When there's lymphatic transport malformation or malfunction there, either anatomically or malfunction because of other reasons, secondary, there's really massive edemas that can occur in patients. So, application of compression, pumps, etc., can be very, very useful for them. So the edema, the way it looks, you can kind of get an idea. Chronic venous insufficiency versus lipedema, lymphedema. The appearance can be a little bit different as well, unilateral, bilateral, etc. All right. So, so again, stage 3, elephantiasis. lymphedema, that's really, really significant, severe skin changes can occur, and there's high risk for infections in open wounds. There's also risk for DVT. So DVT and infections with this stasis in the lower extremity, you want to definitely make sure. So compression therapy, manual lymphatic drainage can be done with, a lot of the massages in the arms or legs, and that helps a lot. Exercise is very important, and then to make sure that the skin care and self care is taken care of in these patients. Garments can be very, very difficult to wear. There, many things that are available in medical stores where they, put those socks inverted and then they put their feet in and they can pull it up. It's very hard when the leg is swollen to have these garments. They're fairly expensive. We also have these Velcro compression wraps. So if they're not able to get the garment up, just putting a Velcro to aid with the compression. Remember, people don't like wearing compression. Not everybody likes that, and especially if it's high pressure, 40 millimeters of mercury or more. It can be pretty uncomfortable. Uh, any compression is better than no compression. That is the a bottom line here. Any compression is better than no compression. If patient's not comfortable wearing too high, it's okay to use lower, but make sure they use some kind of compression. Um, Next would be a wound bed. Like I told you, the principle: wound is wet, dry it; wound is dry, wet it. So alginates, foams, honey, meda honey can be very, very useful to rehydrate the wound bed. It also has some antibiotic properties, antimicrobial actions, hydrocolloids that can absorb fluids. And then if you have a dry wound, then hydrogels can be very, very important for rehydrating as well. There are some ideal dressing, characteristics: absorbing excessive fluid, protecting the wound, uh, preventing bacterial invasion, conforming to the wound shape. And then some of those, if you take off, can also kind of debride a little bit of that necrotic tissue. They do not macerate the surrounding viable tissues. So there's lots of these ideal wound dressing characteristics that you want to keep in mind. Also, remember there are some antimicrobial dressings, iodine, or for odor control, activated charcoal, silver. All these can also be part of the wound dressing, which help in the antimicrobial activity. For tissue growth, with advanced technology, Appligraph, Dermagraph, Epifix, these are, Appligraph would be fetal foreskin, or, placental tissue. All this can be used for tissue growth, and they have these artificial grafts, which help with, if there's a wound that you kind of gotten to heal quite a bit. There's, let's say, about a 5 centimeter by 5 centimeter wound that's left. You can apply these grafts on a weekly basis, which will kind of help with that tissue growth. And then advanced therapy with negative pressure wound therapy, a wound vac, hyperbaric oxygen therapy, growth factors. All this are now used quite a bit. Stem cells, nanotechnology, all these are newer things that are coming with advanced therapy, and it's coming up a big way for wound healing. And then, other wound care techniques and dressings for diabetic foot infections, particularly, like I was telling you, in terms of offloading, you want to make sure that they're not putting pressure on those wounds at all. I'm going to stop right here because I'm already at 9:45. Diabetic foot infections. I want to leave time for questions. I will just tell you that there are a few principles here. We can go over that if we don't have any questions, but I'm going to stop right here to take any questions and give you time.
Are there
Are there
any
any questions?
questions? Any questions from the audience or online? Well, I actually have a question, Dr. Sundareshan. So,
Sure.
as an ID doctor, of course, we always think about infections, but when is the right moment, right time to take cultures from wounds? Because cultures can be, problematic sometimes. And if we don't know how to interpret them, if we don't know where to collect them from, right? At which time, we can be just identifying just commensal pathogens, just contaminants that we don't even need to treat. So when is the right moment and right, I don't know, like area to grab a culture from?
Absolutely. That's a great question. Actually, that was going to be a segue for the diabetic foot infection guideline talk as well. I'll go over that a little bit, but then, if you remember, it starts with wound contamination, colonization, then critical colonization, wound infection, and then severe infection. That's really the spectrum of how, wounds settle in. There's an open breach in skin. There's always going to be something that's going to be settling down from the environment. So when you start seeing any systemic or local signs suggestive of infections, so rubor, choler, dolor, that almost always works. If there's increased pain in that ulcer or open area, if there's a surrounding cellulitis, there's purulence, you start seeing pus in that wound. Those are some of the times that you really want to swab. I also want to tell you that in the hospitals, whenever they see these open wounds which are deep, which don't look that good, many times in the ER they do surveillance cultures because they want to know if the patient has colonization with a multi-drug resistant organism, for instance, MRSA or any other a multi-drug resistant organism. So surveillance cultures are different from actually getting cultures for the patient. And it's also important to get the right kind of cultures, and I'm going to kind of go over that a little bit. These diabetic foot infection guidelines are excellent. If you want to look it up, they're free of cost for from Infectious Diseases Society of America. I've included a screenshot here. It was updated in 2023. And if you look this up, Infectious Diseases Society of America diabetic foot infection guidelines, you can find those as well. They talk about diagnosis. That's exactly what Dr. Rodriguez was asking about. And then they talk about guidelines for who to treat, how to treat with antibiotics. So here they do talk in terms of what is the best way of getting cultures. So superficial cultures are not the best. You see that there is a breach in the skin. There's a long-standing ulcer, especially with diabetic foots, you first do a clinical exam with a probe to bone, PTB, probe to bone. It's very, very sensitive for diagnosis of osteomyelitis. We've seen that picture B. You're looking to see if you're able to probe to the bone. And getting culture here is they do talk in terms of getting an aspiration. You want to try and get aspirate a bone aspiration or a deep culture. And you can see those trocars and other instruments that they use for getting good cultures. Many times these swabs are not really the best way of getting cultures. Bone biopsies or aspiration is the best way to get for osteomyelitis. So swabs, again, even in the context of wound cultures, swabs may not always be the best. You want to get nice deep cultures, and especially if you're suspecting bone infection, bone aspiration or bone biopsy is what you really need for cultures. A long-winded answer, but I hope that covers a lot of the things that come up with cultures.
Thank you.
Dr. Vidya?
Yes, yes.
Yes, this is Dr. Chinda from Cameroon.
Hi, Dr. Chinda.
Thank you so much for a fantastic talk with really so much to learn, even for an internal medicine residency, as we get to manage a lot of these patients. And I had a couple of questions, and the very first one was about negative pressure wound therapy, which you did mention. Now, this is actually practiced here quite frequently by our wound care department. They usually call it wound vac.
Yes.
The main concern I often have with that is that once that is placed, you have to leave it in place for a couple of days, a few days before you get back in there. And my fear is always infection. What if it gets infected? What are your comments about the risk of infection and how to mediate that when applying negative pressure wound therapy? And the second question was somewhat a follow-up to the question that was asked already. It was about the consideration of skin biopsy, for example. A lot of times you get a patients with chronic ulcers, but then subsequently they turn out to have a squamous cell carcinoma. We've been managing it for a venous ulcer, etc. So when do we say, hey, we need to get a biopsy of this one and assess for something more than what we're already considering?
Absolutely. Great questions. Great questions. So, for anybody that has not seen what a negative pressure wound therapy looks like, this is, an ulcer here with that negative pressure. It's just foam. And then they have this pipe that is attached to a little pump which gives negative pressure. So it can be anywhere from 100 to 125 millimeters mercury. So there's negative pressure. It's just sucking on that foam, and the foam is kind of bringing the wound edges together and helping close. And this is a brilliant way of kind of having those tissue growths induced in wounds where you have like a large gap. In fact, started by a nurse. So this is really very, very nice way of taking care of wounds. And you're right, Dr. Chinda, in terms of, we change the wound wax 3 times a week. And when these wound vacs are changed, the foam is right there, and it kind of smells bad. So many times people think that okay, that wound is infected. The key there is how it's handled when the foam is placed. You got to make sure that it's done in a good aseptic ways. And if the wound vac and the foam is placed in a good aseptic way, then definitely you're doing a good job. You're preventing infections. When you remove that foam, also clean the wound at that time. And if you see that there is purulence, there is again erythema around that area which is getting worse, there's any blisters or anything that is suggestive of infection, if there is any systemic symptoms, that's when you take cultures and see if there's any wound infection in addition. But otherwise, the way the wound vac is placed, if it's done in a good way with all aseptic precautions, um, it's actually very good, and not very many concerns for secondary infection of that. And then coming to your second question in terms of when do you suspect that there is probably malignant transformation in the wound? We talked about that in venous ulcers. Typically with a lot of the surgical procedures that we have for diabetic foot infections or any of the other wounds that we have, they do send for pathology. In fact, it's a very important a guideline for us. If the pathology is clear, the margin is clear, we shorten durations of antibiotics. We don't give long durations of antibiotics. So pathology there is very, very important. In addition to cultures, send for pathology when the wound is not healing, when you have these appearances, typical appearances with heaped up edges, the wound does not typically look like a non healing wound. It looks different. The edges look different. There's not very many inflammatory signs there, but it's not healing. So, those are some of the times where, and venous ulcers, that's been long standing with those changes that you're seeing. All those times you should definitely get a biopsy and make sure. So, biopsy are equally important as are cultures for proper management of wounds.
Thank you so very much. And that seems to be all from us here. Great talk once again.
You're welcome. You're welcome. I have about 5 more minutes, and I just want to kind of, tell you one other thing in terms of antibiotic usage. And I think I'll stop after that. Um, from Infectious Diseases Society of America, their guidelines also in terms of, which antibiotics, oral versus IV antibiotics. So for microbiology, superficial diabetic foot infections, gram positives mainly, And then, deep chronically infected ulcers, gram negatives, anaerobes with malodorous wounds, gangrene, etc. You want to think of anaerobes as well. Typically, we think that diabetic foot infections are polymicrobial. This was, interesting information which I thought I would share. So microbiological spectrum can differ from geographic locations. Gram-negative pathogens, multi-drug resistance, especially you see in subtropical climates of Africa and Asia, in contrast to predominantly gram-positive organisms that we see here in the Western Hemisphere. So there are lots of papers to suggest that. So, keeping in mind that particular epidemiology, if you are treating patients with diabetic foot infections, you want to presumptively use antibiotics based off of that epidemiology there. So that's one. And then also in terms of Dr. Rodriguez asked about how to identify infections. We went over that in detail. And in terms of topical, oral, parenteral antibiotics, there are lots of choices available there. Again, depends on the type of bacteria, severity of infections, and then whether there's multi-drug resistance, etc. This is what IDSA has kind of recommended. Mild infection, no complicating features, gram-positive cocci typically implicated. You can get by with oral first-generation cephalosporins, clindamycin, fluoroquinolones. Those are some of the choices. For moderate and severe infections, you do think of a more polymicrobial mixed infections. So a beta-lactam inhibitor incorporation is important there. So beta-lactam inhibitor combinations, second, third generation cephalosporins here. And then also, if there's multi-drug resistant organisms, you may need to go for carbapenems or maybe even combination newer drugs with carbapenem and beta-lactamase inhibitor combinations. So there are some guidelines there from Infectious Diseases Society of America based off of the severity of infections. And then also with pathology, once the pathology margin is clear, they are saying that you could go with shorter durations of antibiotics, as short as, even 5 days, if the amputation's done and the margins are clear. But keep that in mind, when you're seeing the patients and there's still a vascular issue, there's still a problem. Guidelines are guidelines. You always have to keep that in mind when you're treating patients to see what best applies to the patient. So keep the guidelines in mind, but then always customize it for your patient based on their comorbidities and what you find. So I'll leave you with that. And thank you for this opportunity to come and present to you all today.
Thank you so much, Dr. Sundareshan. That was a very, very good talk. Very helpful.
Thank you.
Well, I hope everybody has a very good rest of the day. Thank you for joining. And thank you, Dr. Sundareshan, again for a fantastic talk.
Thanks a lot. Bye-bye.